Hello, good morning students. So this is the topic for 30th May. The name of the topic is allergic conjunctivitis. Last time we have seen bacterial conjunctivitis. In that also we have covered types of bacterial conjunctivitis, then ophthalmia neonatum and virulent or hyperacute conjunctivitis of adult. So today we will start about allergic conjunctivitis. In allergic conjunctivitis also we have two varieties, that is vernal or spring catarrh and flacular conjunctivitis. So they can be asked for your short note in your theory examination. Allergic conjunctivitis. Eyes is one of the first organs to encounter environmental allergens. Allergic eye disease has become a common ocular problem. So in allergic conjunctivitis, it is the inflammation of conjunctiva due to allergic or hypersensitive reactions which may be immediate, that is called as a humoral, or delayed, that is called as a cellular. The conjunctiva is 10 times more sensitive than the skin. So there can be affection of the skin as well as conjunctiva when there is allergy. So allergy is an altered or exaggerated susceptibility to various foreign substances or physical agents which are harmless to the great majority of individuals, but they are harmful to some individuals. The allergic reaction is an antigen-antibody reaction. What is an allergen? Allergen is an agent capable of producing a state or manifestation of allergy. So allergic conjunctivitis is an inflammation of the conjunctiva due to allergy. If something irritates this conjunctiva, eyes become red and swollen. The swollen eyes means if the conjunctiva is swollen, you call it as a chemosis. The eyes also may itch, hurt, or there is a wateration of the eyes. So when there is itching, unless proved otherwise, it is allergic conjunctivitis. The other name for allergic conjunctivitis is pink eye. So how the ocular allergy starts? So allergen triggers a response. The certain substances produce allergy. It looks uncomfortable and unattractive. So when the patient is having ocular allergy, all the times the eyes are red, the conjunctiva is chemosed, it looks red and there is a watering of the eye. So it looks uncomfortable as well as unattractive. Ocular allergy and allergic conjunctivitis are synonymous terms because majority of eye allergy involve the conjunctiva. The pathophysiology is behind genetically predisposed individuals become sensitized to the allergen. So allergic eye diseases accounts for up to 3% of all the medical consultations seen in general practice. So in a general practice, you can have a patient coming to your OPD for itching or redness of the eyes. All the time the parents, if it is a child, the parents will tell all the time he is rubbing his eye. So the milder forms of allergic eye diseases have fluctuating symptoms of itch, tearing and swelling. The chronic form of ocular allergy give rise to severe symptoms. There can be pain, visual loss from corneal scarring, cataract or glaucoma. That is because of the use of steroids. Disfiguring of skin and lid changes. That is in chronic form of ocular allergy if the patient is receiving steroids for a longer time. Allergic eye disease affects a reported 20% of the population worldwide and may be increasing in line with other atopic diseases such as asthma as a result of environmental factors. So how the ocular allergy occurs? So there is a first step of sensitization and there is a reintroduction and then late response. So sensitization, that is crucial when the allergen comes in a contact of a conjunctiva. That is the first step. So the conjunctiva becomes sensitized to the allergen. Then there is a reintroduction of the allergen that results in early phase response. Then re-exposure of mast cell bound IgE to allergen causes cross-linking of adjacent specific IgE molecules. Initiation of cellular activation and exocytosis of preformed mediators occurs. Then there is a phase response. Significant symptoms to a lower doses of allergen starts. Cytokines are released that attract other inflammatory cells. So in ocular allergy, you have a seasonal allergic conjunctivitis and perennial allergic conjunctivitis. In allergic patients, you can see allergic shiner. Allergic shiner is a term used when there is a venous congestion and dark circles around the eyes. You can get this special condition. It is called as a allergic shiner. Then perennial allergic conjunctivitis is a variant of seasonal allergic conjunctivitis. The seasonal allergic conjunctivitis, allergen is pollen, and a perennial allergic conjunctivitis, it is dust, that is house dust, mite, feces, animal dander. But the perennial allergic conjunctivitis is a response to perennial allergens and it is not so common. So in ocular allergy, allergic salute. So this can be asked in your viva examination, what is an allergic salute? So the patient is having concurrent nasal symptoms, having ocular allergy. So all the time he touches his nose or tip of nose with the hand. So itchy nose present a special habitus. It is called as a allergic salute. All the time he rubs his tip of nose with the palm of hand, and this is called as a allergic salute. So there are two types of reactions of allergy, immediate and delayed hypersensitivity. You better know this from your pathology, second MBBS. So immediate hypersensitivity, the 10 days after initial exposure to foreign protein, anaphylactic reaction follows after second exposure to the same protein. It is characterized by circulating antibodies. Delayed hypersensitivity, the sensitization is the property of the cell themselves. The hypersensitivity is caused by prior contact of the tissue with a protein and seems to be due to the development of sessile antibodies on or within the cells, so that when they are re-exposed to the same antigen, a reaction causing cellular damage develops, which may even involve necrosis. So this is a delayed hypersensitivity reaction. This reaction does not occur immediately and reach its maximum only after 24 to 72 hours. Typical example is tuberculin reaction. What is autosensitization? In this case, individual's own tissue protein are altered and thus rendered foreign by a pathogenic agent, either bacterial or chemical acting as hapten. Repeated contacts may result in hypersensitive reaction, that is sulfonamide allergy, and autosensitization induced by the hemolytic streptococcus. So there is immediate, then delayed hypersensitivity reaction and autosensitization. Then there is a physical allergy also. Certain individuals react to physical agents such as heat, cold, light or mechanical irritation by a typical hypersensitive response, often of a articular type. Some individuals are hypersensitive to light of a certain waveband. So what are the types of allergic conjunctivitis? Today we are dealing with only simple allergic conjunctivitis and its management. And the next topic will be our spring catarrh and flacular keratoconjunctivitis. So types of allergic conjunctivitis, you can have a allergic simple conjunctivitis, then vernal keratoconjunctivitis or spring catarrh, then flacular keratoconjunctivitis and giant papillary conjunctivitis. Another they have included, it is a contact dermoconjunctivitis. So allergic conjunctivitis, allergic or hypersensitivity reactions of the conjunctiva are not uncommon. They may be immediate as seen in hay fever, acute or subacute conjunctivitis and vernal catarrh. Delayed reactions are found in fluctual conjunctivitis. Acute or subacute allergic conjunctivitis often associated with allergic rhinitis. And just you have noted this allergic rhinitis, the patient have a typical habitus that is called as a allergic or nasal salute. Allergic salute. The etiology, the condition is caused by exogenous allergens such as pollens, grass, animal dander. So this is an exogenous allergen. In fluctular conjunctivitis, you will deal with an endogenous allergen. Occasionally, cosmetics, chemicals and drugs applied topically can induce a violent follicular or non-follicular reaction in the conjunctiva. In Western countries, the conjunctivitis is often seen as a part of typical hay fever, hence known as hay fever conjunctivitis. It is commonly associated with allergic rhinitis. So, the classification is seasonal allergic conjunctivitis, vernal keratoconjunctivitis, atopic keratoconjunctivitis, giant papillary conjunctivitis and fluctular conjunctivitis. So, sensitization. The conjunctiva is normally exposed to picogram quantities of environmental allergens. They are pollens, dust mite, fecal particles, animal dander, house dust. When deposited on the mucosa, these antigens are thought to be processed by Langerhans cells and other antigen presenting cells APC in the mucosal epithelium, conjunctival epithelium. So there is a typical special type of cell in the conjunctiva that is called as a mast cell. It is one type of granulocyte cell like basophil. The conjunctiva has high population of mast cells, that is in 1 cubic millimeter there is a 5000 mast cells present in the conjunctiva. So in healthy human eye they are present in the substantia propria, but in a patient with allergic conjunctivitis they are found in the conjunctival epithelium also. So in one mast cell there are about 10,000 to 50,000 IgE receptors are present. So what happens? So allergic conjunctivitis is a typical mast cell mediated hypersensitivity reaction. Surface of mast cells loaded with IgE antibody. Mast cells particularly abundant in the conjunctival stroma at the limbus. So this is called as a cascade phenomena. The exposure of appropriately sensitized immunoglobulin E coated mast cell to airborne allergen is the initiating stimulus for allergy. The allergen binds to two separate IgE molecules creating a dimer. It initiates a chain of reaction in mast cell plasma membrane. The membrane ruptures leading to extrusion of contents of the cell to the surrounding tissue. This is called as a degranulation. And contents of mast cells act like mediators of allergic reaction. They are called as a mediators. So in this picture you can very well come to know this is a reaction. There are A, B, C, D pictures. In picture A you can see a mast cell which contains the granules, and there are receptors and as well as immunoglobulin E. So when the antigen or the allergen comes in contact with immunoglobulin E that is present on the surface of mast cell, there is an influx of calcium, there is a cyclic AMP, and the mast cell gets rupture, that is called as a degranulation of a mast cell. So when the mast cells gets rupture, there is a release of histamine, leukotrienes, kinins, heparin and tryptase. So all these are called as a precursors of inflammation. So the mediators consist of the following group. So there are four groups. The group 1 contains histamine and prostaglandin. Group 2 eosinophilic granules. Then group 3 eosinophil chemotactic factor. Group 4 platelet activating factor. So mast cell, it contains histamine that causes vasodilatation. and smooth muscle constriction. It causes itching and redness. The heparin, it prevents blood coagulation. Then tryptase, it potentiates histamine, activates eosinophils and mast cells. So these mediators stimulate proliferation of fibroblasts and recruitment of many cell types in the conjunctiva. These events play an active role in development of papillae in patients of vernal keratoconjunctivitis. So development of papillae follows all these process, that is a cascade phenomena, means one follows the other, that is called as a cascade phenomena. So in seasonal allergic conjunctivitis, it is the commonest and one of the mildest form of allergic conjunctivitis. It accounts for 25 to 50% of all cases of ocular allergy. It is often associated with rhinitis and even sinusitis. 70% of patients provide either a personal or a familial allergic history. Seasonal allergic conjunctivitis can develop suddenly when patient comes in contact with an appropriate antigen such as pollen, grass. So what are the symptoms in seasonal allergic conjunctivitis? The symptoms are itching, watery discharge, rhinitis or sinusitis. The signs in early stages not always present, but you can see lid swelling, ptosis. This is a typical habitus. This is a ptosis, but the terminology used is tylosis. In vernal keratoconjunctivitis, you can see a drooping of eyelid. That is not ptosis. It is not a neurological phenomena. It is called as a tylosis because of the thickened lid margins. There is a conjunctival hyperemia. Hyperemia is a passive dilatation of the conjunctival blood vessels. Then chemosis, that is the edema of the conjunctiva. Then papillary reaction and follicular reaction because of the allergic response. It is a response of conjunctiva. So what is the treatment? The three aspects of treatment are allergic avoidance or allergen avoidance, systemic antihistaminic drugs you can give, or topical drug therapy. To keep patient away from allergen is not possible. It is the most difficult part to pinpoint the allergen which is responsible for the particular allergic manifestation. So in seasonal allergic conjunctivitis, you can have a prevention, that is elimination of allergen. Avoid wearing contact lenses until symptoms and signs resolve. This is education for the patient who is wearing contact lenses. Then avoid rubbing the eyes, because the rubbing of the eyes will cause the rupture of mast cells and there will be release of histamine like precursors of inflammation. The cool compresses and preservative free lubricants, they are prescribed. The cool compresses or cold compresses, they will have an effect on numbness, so there is no itching and there is no rubbing of the eyes. So how to avoid the allergen? Avoidance of allergen, that is, you have to limit the outdoor activities. You have to use air conditioning or air filter system. Then if you are driving a car, you have to drive the car with windows closed and use protective eye gear when you are outdoor. So maximum you have to avoid the allergen. For the children, you can restrict some play activities in the outside. So this is how you can have a recommendation for the avoidance measures. In general, you can have protective eye wear for avoidance of allergen. Then you can away from the pets. Then you have to fix the leaks, use dehumidifier, remove carpets. So there is a cleanliness that is an important. Wash moldy surfaces with bleach solution. For the dust mite, you have to use allergen impermeable mattresses and pillow covers. Reduce exposure and car and upholstered furniture. Minimize clutter. Wash linen and washable items. Seasonal pollen and outdoor molds, keep windows closed. Air conditioning, Avoid locations likely to have high levels of seasonal outdoor allergens. Wash hands, brush hair. So this is all comes into the health education of a person. As ophthalmology is having a comprehensive eye care, you have to prevent, promote and cure. Diet also you have to avoid allergic foods, elimination of diet and re-challenge. Multifaceted environmental control interventions are important. Desensitization against specific allergen can be possible, but systemic antihistamines may be given. Astringent lotion, adrenaline 1 in 10,000, antihistaminic drops, that is chlorpheniramine, mast cell stabilizer, that is sodium chromoglycate, olopatadine, ketotifen, or short course of corticosteroid drops. So avoidance, desensitization and treatment of the eye drops. And you can have also a lubricants eye drops. So this is a pictorial graph where management options. You can have when the allergen comes in contact with a mast cell, the granules containing a preformed mediators, they will be released. So with an arachidonic acid pathway, the prostaglandins and leukotrienes are released, histamine is released, the chemotactic factors they are released, so there is inflammation of the conjunctiva, it starts itching, there is a watering, there is hyperemia, so all can be halted. So you can use mast cell stabilizers, you can use non-steroidal anti-inflammatory to block the arachidonic acid pathway, you can use antihistaminics, that is oral, then you can use steroids. So all these management options are possible in an allergic conjunctivitis. The steroids, a special mention for steroids, that is steroids has to be reserved for treating severe allergic disease. Use generally add-on therapy for short periods. Lowest maintenance dose, just enough to suppress inflammation. Surface acting steroids, that is loteprednol or fluoromethanolone, you can use. And potent steroids only for very severe disease, because the side effect of use of steroid eye drops are have to compared with the benefits to the patient. You have to use as a monitor use, because generally many times it happens that the patient purchase the drugs, that is called as a OTC, over the counter. With your older prescription, the patient can go, and whenever he is having allergic conjunctivitis, because it is a common disease occurring in March, April and October. So there is a seasonal variation, and the patient have his old your prescription sheets, so he can go and purchase. So you have to tell to the patient the side effects of the steroid or the eye drops, that is unsupervised use. You have to ask the patient, there should not be any unsupervised use of the eye drops, because you have to monitor the intraocular pressure when you are giving a steroid drops, and also the lens status, that is the cataract formation. Steroid response is higher in children, so you have to be careful while prescribing a potent steroids in children. त्याला आपण असं म्हणतो की लोहा गरम है मार दो हातोडा, म्हणजे when there is a need you have to use a potent steroid, otherwise you have to reserve this for severe allergic disease. Mild to moderate allergic conjunctivitis, you can go for topical cromolyn sodium or ketorolac-tromethamine, then lodoxamide tromethamine 4 times per day. It acts faster than cromolyn sodium. Dark classes for photophobia. So these are the some mast stabilizers in your viva. You can be able to tell the examiner the names of the mast cell stabilizers when the question goes on allergic conjunctivitis. Cromolyn sodium, the mode of action is stabilization of the mast cell membrane by preventing calcium influx across the cell membrane, which prevents degranulation. So they are called as a mast cell stabilizer. Another one is lodoximate, that is 2500 times more potent than cromolyn sodium. Additional inhibiting action of the drug on CD4 cells and eosinophils, reducing the inflammatory process. Azelastine, that is 0.5%, action starts within 3 minutes and effect lasts for 8 to 10 hours. It exhibits effect on multiple components of allergic response. Ability to inhibit preformed mediator release from mast cells, release of histamine leukotriene and biosynthesis of eosinophil chemotaxin. Then non-steroidal anti-inflammatory drugs, they block the cyclooxygenase pathway, limiting production of prostaglandins and thromboxane. Indomethacin, 1% aqueous solution can be used. Ketorolac-tromethamine, 0.5%, 1 drop 4 times a day. Flurbiprofen, 0.03%, and diclofenac, that is 0.1%, you can use as a NSAIDs. Corticosteroid, just I told, that is indicated for severe inflammation of the conjunctiva and cornea. Depot corticosteroids may also be administered by supratarsal injection. 10.5 mg of triamcinolone is indicated subconjunctivally under the upper border of upper tarsus. So this is a depot preparation. This can be also the use of steroids. You can write in a short note where the steroids are used, the injectable steroids. Cyclosporine, potent immunosuppressive agent which control cell-mediated immunity by inhibition of activated T lymphocytes. In uncontrolled cases, treatment with sodium acromoglycate, steroids, and 2% cyclosporine has shown to improve the condition. So herewith we are finishing today's topic, that is allergic conjunctivitis. The next topic we will cover vernal catarrh and flactular conjunctivitis. Thank you. What is allergic conjunctivitis? एवढंच लिहायचं.